Hey everybody, welcome to Coffee and Cases. It's 2:59, so we're just gonna wait another minute or two before we get started. And I know it looks like I'm in an electrical, what would you call this?
Um, Electrical room.
Electrical room. And you're right, but it is my office. And it's actually really, really cute on all the things that I can see. Just the things that you can see are not so cute. Okay, but we're gonna wait like maybe 2 more minutes and then we're gonna get started.
Sorry, Ruth, I'm just having some difficulty sharing here. It doesn't seem to be a WebEx issue. It's like WebEx accessing my computer.
Okay,
So I may need you to share a presentation.
you bet. I have it open here,
Sweet,
Tanya,
thank
so
you.
I can certainly share it when the time comes. And yeah, I just want to acknowledge that WebEx is nobody's friend. Um, Thank you guys for bearing with us. Our producer, Ashley, has basically been in tears with all of the hiccups and cancellations of the meetings and the links being down and SHAIT trying to support her through it. So thank you for being patient with all of the emails. She is actually doing a phenomenal job and we really appreciate her. It's 3:01. I know that people are going to keep on kind of trickling in here, but just because there's really important topics to cover today and I want to use up all of our time, I think we will get started. So first of all, for our land acknowledgement, while we meet today on a virtual platform, I'd like to acknowledge the Indigenous peoples of the lands that we are on today and take a moment to acknowledge the importance of the lands which we each call home. As we gather here today, we pay our respects to the First Nations and Métis ancestors and reaffirm our relationship with one another. The purpose of these virtual rounds, again, is to discuss pertinent topics kind of throughout the continuum of stroke care. This WebEx is somewhat secure, but we are going to be respectful and not share any patient information. And any cases that we kind of talk about are de-identified and are kind of just a foundation of general discussions. And again, we're just so grateful for this Coffee and Cases community and that we're able to share and learn from each other. And I know a lot of you have expertise in stroke as well. And thank you for those that have reached out and asked if they could present. We are kind of working up all the future sessions and are going to include some of you guys in it. So that's great. Don't be afraid to chime in, ask questions, give comments throughout the sessions. It is great to learn from each other, and we want to make this as friendly and as helpful a session or sessions as we can. And I just think maybe we've been a bit remiss in not introducing ourselves, your hosts, a little bit more thoroughly because I know some of you are new. So um, I will let Brett, the good Dr. Graham, go first.
Hi, I'm Brett Graham. I'm a stroke neurologist here in Saskatoon. I'm a Sagittarius. I don't have coffee today, but I do have lukewarm tap water.
And what do you do for a living, Brett?
I'm a stroke neurologist by day. Yeah. And I drive children around to activities by night.
Okay. And I'm Ruth Whalen. I'm clinical nurse specialist for stroke services located here in Saskatoon, but certainly reach out across the province. And I was lucky just last week to be in Yorkton talking with nurses and docs there and some interprofessional practice members. And it was fantastic. It was a great trip and we had such a good time. And I just love our stroke community here in Saskatchewan. And then Ashley, our producer.
I'm Ashley, and I'm in the same room as Ruth and Brett here, so it's just echoing. I work at the stroke prevention clinic. I don't know how to mute this. That's okay. And I also drive my kids around to a lot of hockey. About it.
Yeah, so thanks, Ashley, for being here with us. So today we're going to be looking or taking a bit of a interprofessional practice and a PT, OT kind of perspective to stroke. And we're so lucky to have two people here to share. I think we will start the session off with Tanya and then flip over to Caitlin afterwards. So Tanya was born and raised in Montreal, Quebec. Enchanté, Tanya.
Bonjour. Ça va?
We speak really fierce Saskatchewan French. Cheers.
And Duolingo Spanish.
And do this guy. She completed an undergrad degree in pharmacology before obtaining her medical degree in 2020 from McGill University. Upon completion of medical school, she moved to the prairies to pursue residency and training in physical medicine and rehabilitation at the University of Saskatchewan. She is in her 5th year residency. Her primary interests lie in musculoskeletal rehabilitation and pain medicine, with a particular emphasis on image-guided procedures. So Tanya, we are so lucky to have you here. It's interesting, a lot of people have never heard of the word physiatrist. So we are so glad that you are doing a residency in physiatry, and we're happy to have you here speaking about post-shoulder pain. And I am going to pull up here your post-stroke shoulder.
Thank you. I also have rarely heard of a physiatrist, if I'm being quite honest. Still sometimes don't even know what I do, but we do something.
I am trying to get this into sharing mode. Let me see. There. How does it look? Okay. So you just tell me, Tanya, when you want me to bump it. Oh, oopsie. All right. Take it away.
All right. So yeah, my name's Tanya. I'm a 5th year physiatry resident, kind of fresh out of Royal College studying and exam and everything. So I'm kind of cruising right now, which is really nice. Today for the topic, I decided to discuss post-stroke hemiplegic shoulder pain, which sometimes I'll refer to here as like HSP. It's a very common issue in stroke rehab, one that significantly impacts recovery, tends to affect participation in therapy as well. And then we see that it also affects overall quality of life. I'll take you through the current evidence, the recommendations. Really what we like to focus on are the Canadian Stroke Best Practice Guidelines, and then there are some other resources as well that we'll look at there. So I'll get you on the next slide, please. I think we got the learning objectives. Yeah, so by the end of this session, I hope everyone will have a bit of a better understanding on the prevalence and causes of shoulder pain after stroke, hopefully be able to at least understand the components of a focused assessment, summarize the evidence-based prevention management strategies, and then we'll also look at a practical multidisciplinary sort of approach that can be used in a clinical setting as well. Next slide, please. Thank you. So why HSP matters. So shoulder pain is one of the most frequent complications of stroke. It's reported anywhere from 16 to 72%. It said a prevalence of 16 to 72% in survivors, depending on the timing, depending on the criteria used in certain studies. It's not just uncomfortable, but as I mentioned before, it tends to interfere with participation. It limits upper limb recovery. It worsens quality of life. And then the pain can eventually lead to learned non-use, where patients will actually stop trying to move the affected limb, essentially affecting the recovery and what kind of quality of life and functioning they can gain from that limb. So that's why prevention and early recognition are really something that are key in this matter. Get to that next slide, please. So this here is, I actually quite like this diagram here. It's maybe a bit outdated because they use the term shoulder hand syndrome, which refers to CRPS, complex regional pain syndrome. But I like this because it breaks it down into the different things that can go wrong. So there's certain causes of pain that can be related to impaired motor control. Then we have to consider soft tissue lesions as well. And then there's the altered peripheral nervous system, central nervous system activity as well. Overall, HSP tends to be multifactorial for the most part. Causes can include many things. All of them are listed here. I've circled the three of them in red here, which tend to actually be the most frequently associated causes of HSP. So you can see the glenohumeral subluxation, and that's where the humeral head will actually drop slightly out of the socket because of the muscle flaccidity. It is controversial whether that actually causes pain or not. Some say it does, some say it doesn't, but it is something that technically is on the radar here for HSP. Adhesive capsulitis is another big one. And then spasticity as well is the third biggest one here. When we're talking spasticity, we're talking really more about the muscles that pull the shoulder inward. So we're talking about the subscapularis muscle and the pectoralis major muscle most commonly. The other two that I'll highlight are essential post-stroke pain and complex regional pain syndrome. Those can also contribute. But ultimately, most patients do tend to have more than one mechanism going on, which translates to treatments need to be individualized. All right, next slide, please. So when assessing someone with shoulder pain, we start with a detailed history. When did the pain start? Does it occur with rest? Does it occur with movement? What's the pain characteristics like? Is it sharp, dull, burning? And then I like to observe posture, alignment, scapular position, palpate for any sort of tenderness, assess passive range of motion. When assessing passive range of motion, I'm particularly paying attention to external rotation and abduction because those tend to be the first two ranges of motion that are lost in adhesive capsulitis. In terms of subluxation, I like to measure that using finger breadth palpation, but again, this needs to be interpreted more in context because not all subluxation causes pain. And then if presentation is atypical, always consider imaging for fractures, rotator cuff tears, infection, different sort of underlying processes that can be responsible in this sort of situation. Next slide, please. So this here actually came directly from my study notes. This is from the Canadian Stroke Best Practice Guidelines, but then my little highlights from where I was studying from. So the Canadian Stroke Best Practice recommendations emphasize prevention from day one. We want to educate staff and caregivers on safe handling, so never pulling on the affected arm. We want to support the arm as much as we can when sitting or standing, and that'll look different depending on what the patient's ambulation is like. So if they're mobilizing more in a wheelchair, we're looking at things like an arm trough or a hemi tray or a pillow or something to stabilize that arm. Whereas if you're standing, slings, we'll talk a bit more about slings. They do tend to be quite controversial, and they actually discourage the use once you're out of that Brunstrom stage 1, like the Chinook McMaster stage 1, the complete flaccid stage. But sometimes if you really need a sling, we can consider something called a give more sling. I'm not sure if anyone has seen one of those before.
Arm bike that sits in the back.
Okay.
It's really light and stuff.
Yeah.
I lent it to the hand program just for a couple weeks to try. I'm going to put it in the yellow book. Lisa,
Sure.
the hand program
Yep.
asked, she can try it.
As long as it's signed out.
I'll sign it out there, and then I told
Oh, I think someone is unmuted.
Oh, I thought someone had a sling or something to show me. I was like,
Oh.
it's too convenient. Yeah, so we want to support the arm when they're sitting, when they're standing, use proper positioning, and start gentle range of motion early. We want to avoid painful overstretching. Taping is something that can be used to help reduce pain. We want to monitor the pain regularly. That's something that's quite essential to do. And then really at the end of the day, prevention is about positioning, protection, and partnership with the patient. Oh, this is gone. I'll get you on the next slide, please. So when it comes to non-pharmacological treatments, we mentioned positioning and handling that are really the cornerstones of management. Taping is something that has moderate evidence for short-term pain relief. Supportive devices like slings can help short-term, but if you wear them for too long, they can promote disuse of the limb. The other thing is once they're past that stage 1, the completely flaccid stage, it also tends to promote the spastic positioning. So it can make their spasticity long-term worse as well. So we tend to avoid those as much as we can. Or if we are considering a sling, we're considering a sling that doesn't put them in that spastic positioning. Gradual range of motion exercises and strengthening are key to recovery as well. Neuromuscular electrical stimulation, or FES, functional electrical stimulation, has good evidence for preventing subluxation and improving comfort as well, especially if you start that early. And then manual therapy and mobilization can also improve mobility and reduce stiffness. Next slide. So when conservative management options or conservative measures aren't enough, we start to consider pharmacologic options. So we start with the simple stuff, things like acetaminophen, NSAIDs if they're appropriate in the clinical context. Steroid injections into the shoulder are possible, but really that's only should be an option if it's an inflammatory or arthritic process that's underlying this shoulder pain. Suprascapular nerve blocks are something that can be used in specialized settings for short-term relief. And then for spasticity pain, we mentioned the pectoralis major and the subscapularis muscle. Botox injections into those muscles can be considered, and they have pretty good evidence actually for reducing pain and tone and improving range of motion. Next slide. So to summarize the evidence here, taping and neuromuscular electrical stim have moderate quality evidence. They're recommended by the Canadian guidelines. Botox shows modest but meaningful pain reduction in several RCTs. Supportive devices have mixed results, again, depending on the timing post-stroke that they're used. They can help temporarily, but they shouldn't replace functional use of the upper extremity. Overall, a multimodal approach is what is best. We want to be combining positioning, stimulation, exercise, and sometimes pharmacologic treatments or interventional treatments. Next slide, please. So here's my little approach of how I like to approach hemiplegic shoulder pain. A post-stroke patient presents with hemiplegic shoulder pain. The first thing I always want to ask myself is, are there any red flags here? That's the first thing we want to make sure. So are we dealing with possibly a fracture? Are we dealing with infection? Are we dealing with CRPS, complex regional pain syndrome? If there's any indication for any of those, we're either moving towards a referral or imaging, depending who the professional is, of course, who's assessing for this. Once those are cleared, we can move on to step 2. So initiating early management. So that's initiating early measures like positioning, education, gentle passive range of motion. Step 3, if there's subluxation, we're adding neuromuscular electrical stimulation or taping. My step 4 here, if there's spasticity causing painful postures, we're considering Botox alongside the therapy. And then my step 5, which really is just this ongoing thing of reviewing and adjusting regularly based on the patient's response. And that's where really multidisciplinary teamwork is essential. PT, OT, nursing, physician, everyone plays their role in kind of acting together to address this cause of pain. So yeah, just reassessing that stuff regularly and then escalating towards a block or a specialist injection if they've got this persistent severe sort of pain. Next slide, please. So to recap, hemiplegic shoulder pain is something that's quite common. It's multifactorial and tends to be preventable. Early intervention is something that matters. The Canadian Stroke Best Practice recommendations highlight positioning, taping, gentle movement, and monitoring. Neuromuscular electrical stim and Botox are supported by moderate evidence, and immobilizing slings and aggressive stretching are something that should be avoided. But most importantly, management is something that is team-based and should be patient-centered as much as possible. So my next slide, I think, is just the references here. It is just a short form of references for anyone who'd like to read more with regards to those. I can also provide a full rep list as well. I think there were about like 20 references here, a lot of which are these kind of RCT studies that were done on each of the specific modalities. So hopefully that was helpful. And hopefully
that was really
fast.
No, that was really helpful, Tanya. I know that there was some questions that Ashley had received. You could probably just speak through my mic if you just talk out loud.
Can everyone hear me if I talk loud like this?
Yep.
Yeah, okay. So one of the questions I have is the use of modalities of like the TENS machine and how often to be using that application.
Yeah, so the guidelines don't actually specify a frequency for like the neuromuscular electrical stim or TENS. But if you actually dig a little deeper into the guidelines and you look what studies they pulled them from, each of the studies that they got their evidence from tend to use the neuromuscular electrical stim for starting 2 hours a day, and they'll sometimes go up to 4 to 6 hours a day. They don't specify how frequently they do it, but the thought is it should be at least 5 times a week. But it's not actually written in stone how frequently it should be done, or like nothing is really that clear. All of this is really coming from RCT studies.
Okay, and then another question I have here is,
Someone was wondering about the upper extremity supports for hemiplegic arms, options for both wheelchair and ambulation.
Mm-hmm. Yeah, so those were the ones that were listed in there's a good little blurb on that in the best practice guidelines. That would, for the wheelchair, we're looking at like an arm trough or a lap tray. Sometimes you can use a pillow as well if you're quite desperate, I guess. And then the ambulation one, again, I would say to avoid use of the conventional typical sling. And if you need use of a sling because that arm is subluxing when you're ambulating, if you're ambulating on your feet, to try something like a Give More sling.
Okay, I have one more. When would you not use Botox for spasticity?
Yeah, that's a good question. So the way I think of when I wouldn't use Botox is basically I say, would I use Botox? And if the answer is no, I wouldn't use Botox, then that's when I don't use it. But I'll say why we do use Botox. Reasons we would use it for the upper extremity would include things like, so cosmesis is one, pain is another reason, if we deem the pain to be secondary to spasticity. Sometimes it can actually help with the positioning of the upper extremity to improve their functional tasks. If we want to know more specifically what situations you're not using it, then we're really talking about the contraindications of Botox. And then we're talking more like, is there some kind of neuromuscular junction issue, some kind of myopathy going on, something like that, where we need to be considering the contraindications for Botox. But the question is, generally when it comes to Botox is what kind of advantage what is the goal of the Botox? And can it provide some kind of benefit in terms of pain relief or improving function?
And Tanya, I have a question just in terms of accessibility for like our patients, because our stroke patients are spread all throughout the province and spoiled in Saskatoon to have easy, access to physiatry as well as to some neurologists who do Botox. I'm quite confident that Regina has easy access or accessibility to Botox. What about the rest of the province? How would you suggest they get these kind of services for patients?
It's a good question. I can't say I know the answer specifically.
Okay.
Generally, Botox injections into muscles like this do need to be done by professionals who are trained in that regard. We do see a lot of patients in our clinics who do come from, they'll have 4-hour commutes from up north, for example, they'll fly in, that sort of stuff. So that is something that we commonly see in our outpatient clinics, and we'll see people like that in our spasticity clinics themselves. So I would, if you're able to get to the city somehow, it is something that we repeat generally every 3 to 6 months. But we do have a lot of patients who come from north and the periphery into our clinics. But that it's not something that can really be done in a smaller community setting. I guess they're the smaller, I'm blanking on the word, but you know what I'm trying to say.
Some of our peripheral sites.
Yeah, exactly. There we go.
So do people feel confident in referring to physiatry or neurology for these types of treatments, or is there a need for more information on how to access services? I don't know if anyone has a comment or a thumbs up or a thumbs down.
Thumbs down.
Fran says, I think that means no, you don't know how to. I should have prefaced it. Okay. Is there any other questions?
There's one more.
Oh,
There's one in the chat.
okay. Comments in the chat.
Can you speak to chironeurolysis and how this compares to Botox?
Oh, chironeurolysis.
Yeah, so cryo is actually very cool, and it's starting to emerge in this province, which is very exciting, actually. How does it compare? It compares mainly in terms of how long it lasts and the effects long-term around to the muscles around it. Like there's I don't know if you guys are familiar with the name Paul Winston. He does a lot of these studies out in BC, a lot of cryoneurolysis studies, and he does them for spasticity specifically. Sorry, my dog is just yeah, so we have a couple physiatrists who actually spent a couple days training with him. What's nice about cryo is the length to which it acts. So typically cryo will last for anywhere from 9 months to 12 months. So that's something that's more long-term than Botox, where you're repeating it every 3 months. If you actually look at the absolute cost as well, cryo is something that can actually be cheaper, but right now it's not covered by the government. So it's not necessarily something that patients have funding for, which is a little bit frustrating. But they're working to kind of push that forward and see if we can get more coverage for that over time. Yeah, how it compares to Botox. Ultimately, if they're responding to Botox, but it's just not lasting long enough, or they have issues with access, then we'll consider things like cryo, or if it's been a longer time, just because we know there's those structural architectural changes at the level of the muscle as well, which they're not really seeing as much of with the cryoneurolysis.
Do you mind just defining what cryoneurolysis is?
So it's this, you're basically, what you're doing in as basic terms as I could put it is you're putting a needle in at the motor fibers, like the ending of the nerve that are innervating a specific muscle you're targeting. And it's a special needle that when you click this button, it has a nitrous oxide canister running through it, and it creates an ice ball around the nerve to damage the nerve. It doesn't entirely kill it, because we know that would cause neuropathic pain, but it actually damages the nerve just enough to essentially cause the same effects as Botox, to affect the motor function.
That's fascinating.
Yeah, it's a very, very cool technique, and they're also using it a lot in pain medicine as well for certain nerves, that sensory nerves and all that kind of stuff. So sometimes when people, I mean, this is a bit of a tangent, but sometimes when people aren't candidates for certain surgeries, they'll do it as well for different factors over there.
Okay, great question, Sarah. Thank you. One question from Battleford Union Hospital Stroke Clinic. Who can the referral come from for Botox or for Physiatry? Does it have to come from the physician? Can it come from therapists?
No, I think it has to come from the physician. That's my understanding, at least. It's kind of a doctor-to-doctor referral. So it's the therapist would have to be in contact with the family doctor or whoever the practitioner is that's following them. And then just a referral into our outpatient department.
Okay. Thank you, Tanya. Please stay on for the rest, just in case there's more questions that trickle in. Thank you so much for presenting. That was really interesting. And be encouraged, because there is people who've already asked for the recording of this session, because lots of interest in anything therapy-wise and improving access to care and just promoting self-knowledge and the ability to provide care in our own hospitals. Okay, Caitlin, so glad you're here. Caitlin is a physical therapist with Five Hills Qu'Appelle Tribal Council, based out of the All Nations Healing Hospital in Fort Qu'Appelle, performing full scope of practice. She's been working as a physio for the Five Hills Qu'Appelle Tribal Council for about 2 years. She completed her undergraduate degree in general sciences from the University of Lethbridge, and while she was a student athlete playing university women's hockey. Following that, she completed a Master's of Science in Physical Therapy from Robert Gordon University in Aberdeen, Scotland. What? Let's do it for Scotland, Caitlin! She is grateful for the learning opportunities and perspectives she's gained, and that she's been able to bring back to our Canadian healthcare system. She right now lives in Regina with her husband. She enjoys golfing, playing hockey, and she's trained for a few half marathons, and also enjoys time outside gardening. And Caitlin, thank you for being here. We are excited to hear about your perspective of providing culturally responsive stroke care.
Thanks for having me. I will preface and say that my hat is definitely not as evidence-based, I'll say, as Tanya's. So it's definitely more lived experience, just based on having been here and working in it for the last number of years. So is my presentation still showing like little slides, or is it full screen?
No, it's showing little slides and the main slide. There you go.
Better? Okay. So yeah, my name is Katie Fisher. Like Ruth said, I'm a physical therapist with Five Hills Qu'Appelle Tribal Council, based out of All Nations in Fort Qu'Appelle. So just for those of you who aren't familiar with our organization, I'll give a little bit of a background. We are an affiliate hospital of the SHA. So because I'm an employee of FHQTC Health Services, my role is kind of split between servicing our 13-bed inpatient hospital at All Nations, and then the rest of my time is spent with all of the outpatient and community services to the 11 nations within the Tribal Council. So the role has been a pretty steep learning curve coming here fresh out of school, but I'll give a little shout out to our community next door in Melville, because the therapist there has been my lifesaver for many times. So that's good. But the dynamic of our organization is quite unique in the focus of our integration of Western and Indigenous healthcare. So one of the core values the organization has kind of strived towards all of our staff embodying is the spirit of cultural humility. So this differs a little bit compared to cultural responsiveness, and that cultural humility is precursor to being able to practice that cultural responsiveness. So they've really pushed working to learn, listen, reflecting on our encounters with our community members to respond in an appropriate way when they express what they need from us as healthcare practitioners. The organization's developed a lot in the last number of years due to strong connections with our communities and the opportunities for the members to feedback what they need in terms of gaps in care so that we can better fill that need. In the past, when consistent feedback has been collated regarding a gap, the organization has worked with stakeholders and community needs assessments to develop that culturally sensitive programming. So a few of the programs that they've kind of done in the past as a result of some of those needs assessments is Rising Bear, which is their dialysis program. And they've just expanded to offer 6-day dialysis. So that's really exciting. And in response to that integration of Indigenous and Western medicines, they have cultural practitioners within the unit offering traditional teas, medicines, smudging, and have counseling for kidney health with some of our cultural practitioners. We also have Women's Health Center, which opened in response to same thing and needs assessment, which includes a midwifery-led maternity care program, Indigenous birth support worker, and as well now has a female physician working out of there as well to provide women in the community a place closer to home for their birthing supports and utilize traditional practices for some of that. So then that's where we came along in our rehab services, as there was no consistent or stable rehab services for our First Nation communities in the area. So worked on a needs assessment with the University of Saskatchewan to open our program, which opened in July of 2022. So we were very fortunate at that time to get our therapy gyms completely renovated and fully equipped with ceiling track, accessible washrooms, and oversized plinths. And I mention all of that stuff because I know that a lot of the rural departments across the province don't have the equipment capabilities to be handling patients that have higher levels of impairment. So we've been quite fortunate in that aspect of things as well with our staffing, that we've had consistent staffing as well, so that those patients that require higher levels of support or assistance of two, I'm very rarely lone working. So that aspect of things has been a huge blessing, and I know we're very fortunate for that in our area, because as I say, a lot of rural departments don't have that luxury. So since that time, we've had an ongoing learning process developing our rehab program. Oh, sorry, I'm kind of talking and not moving along my slides, but there's not really much to see here. Just a little bit of pictures for us. Oh, and that's our department. And then as well, there's just a few pictures of some of our equipment and what our gym space kind of looks like and stuff. So that's good. Since that time, it's been an ongoing learning process for developing our rehab program that is community and patient driven. So the one thing we've tried to keep in mind is that the community members identified the need for our services. So they should be identifying what they need out of our service as well. And with how our training and education, we can be partners in that vision. So I just wanted to share, a bit about our organization and departments to kind of give a bit of context for some of the areas of the province that may not really know a lot about our hospital and organization. But as this is Coffee and Cases, I'll share a bit about some of the pathways that we've had coming through in the last number of years, and just a few cases that really clarified our vision for providing care in a traditional, or I guess like non-traditional way, depending on what lens you're looking from. So typically the pathway for somebody who has had a stroke to enter our service either happens through acute care or as outpatients who have returned to home in the community and are needing further therapy. Often our acute care pathway is sometimes a little bit convoluted, as often, like, we don't have any rehab specific beds in our hospital at the moment. So when somebody does come back, it's usually because they weren't a candidate for inpatient rehab, or they're looking at being placed in a long-term care facility closer to home that we assist with some of that discharge planning for. Previously, we did have somebody who came back from tertiary care and was kind of coming back for that reason. They had spent a couple weeks in tertiary. They weren't making much progress in terms of alertness or ability to engage. So came back the way a lot of our patients do in this way, with full lift, heavily aphasic, that kind of thing. So when they got back to our hospital, we got a referral just to assist nursing with some pressure management strategies to make sure they had no skin breakdown. But when I went in there, they were like really alert and doing really quite well in terms of engaging throughout the assessment, trying to verbalize. So we kind of began working a little bit more intensely and started noticing some improvement in activity tolerance and sitting balance and all of that kind of good stuff. So from a rehab perspective, we were pumped. This is so great, they're improving, but kind of didn't really foresee that emotional response from family, who had been kind of forewarned that this might not be the best situation for the patient and that end of life might be closer than what they thought. So we had a family meeting discussing whether or not we were supposed to be pursuing a rehab bed, or kind of where we were going to be headed with planning. The attending physician did a really good job in terms of visiting with the family to discuss that portion of that maybe we weren't as close to end of life as we originally thought. And so the family did decide that, we should pursue a rehab option for them, which was exciting. But following their decision, it was still a difficult process. I mean, naturally, with somebody who was previously independent, there was a lot of grief and mental health coming along with some of the new impairments. So we linked in our cultural practitioner, and throughout the month awaiting the rehab bed, the patient was able to smudge, spent time every day with our cultural practitioner. A happy accident that it happened to be around our Treaty 4 gathering, and we were able to get clearance from the physicians actually to take them down to the feast that was happening. So we pushed them through their, I'm losing my name here. There we go. We pushed them in their wheelchair to the Treaty 4 grounds, and they were able to sit and enjoy the feast with other community members. And although it was only a month until the patient was transferred out, we saw a huge change in demeanor, engagement, overall perspective on their newfound situation. And family members were making comments like they weren't anticipating that level of engagement, laughter, all of that kind of stuff again. So the thing that really actually stuck out to me the most about that situation wasn't really that the patient was now running a marathon or had made this miraculous recovery. It was more so about the opportunity that the patient had to heal that was more than just about physical health. And there was definitely improvements in swallowing and trunk control and awareness and all that stuff that we look for, but they didn't regain functional independence, and sometimes that's the way that it is, but there was improvement from being able to access that cultural and emotional piece under the same roof and bring back laughter and new perspective on that situation. So I think that one of the biggest things I learned from that is that I just need to kind of remind myself that we get focused on kind of that physical portion when we're in this role, but there's other ways that people heal. And that looking at that, it allowed a family member to be able to kind of have their family member back in the way that their personality was prior to that. So I think that was a really big thing. And just being able to step back and let patients show you what their version of healing looks like, and realizing that it comes in various forms, was really important. And I think I'd advocate for that every single time after seeing the difference in somebody, even though it wasn't necessarily physical. The one thing I truly love about my job in our workplace here is the opportunity to be flexible. So sometimes, again, we get hung up on that physical aspect of maximizing our 30-minute therapy sessions, but because it may be the only time in a day that a person gets to access that therapy. But I've also learned to be open to the ways in which they know healing works for them, and maybe things that we don't learn in school. So it's allowed me to recognize that, as I kind of mentioned earlier, maybe pushing their wheelchair outside to get some fresh air and visit with somebody they knew was more important that day than participating in our 30-minute session. I kind of feel that core vision of practicing our cultural humility has led me to strive to respond to my patients' needs in a way that is culturally responsive, but it's never really stops. It's just learning and evolving and as I learn more about what's important to my patients, it pushes me more in that direction. It also kind of humbles me every day at how I'll truly never understand somebody else's experience. So we have to let go of what we think the situation's going to be and allow them to walk it through it at our pace. The other thing is, when I think back to cultural humility coming before responsiveness, it's pretty clear why one must become before the other, because we have to be able to strip away our biases, ways of knowing, and make space that our patients can offer us teachings and offer us new ways of knowing as well. And once we get to that place where we can really listen, the ability to respond appropriately finds us, because we just gain a better understanding of what they need. So this case also really challenged me as a therapist in making those decisions, that there are times when it's equally important to support the cultural care of a client, even if it does come at the cost of traditional therapy time, because it pushes the boundaries of what we know works in terms of rehab with task practice and brain plasticity and not wanting to skip a day of input. But I do feel that the balancing act between that is what contributes to the best outcomes, because holistically, it creates longevity in the rehab process. And that's what we know delivers the best outcomes, when patients are motivated, consistent, and diligent in working towards their goals. So I have one more kind of little short piece. Is the other avenue where we access our program following a stroke is through our outpatient and community services. And so when our program opened, we had a patient who had come to us following a short admission at inpatient rehab, and they were provided an opportunity to stay and continue on with their inpatient rehab and get that multidisciplinary feedback and intensive task practice, but had declined to remain in the program. So when they came to us, we were kind of like, what's going on? Like, you had this great opportunity to get everybody in the same place and intensive task practice, and kind of like, why did you come home? And they went on to share that being away from their family with the travel barriers was a huge part of it, and that actually being in a long-term resident in a rehab setting like this made them feel like took them back to residential school days of having been admitted in a facility when you weren't actually quote unquote sick, you were just a resident staying there, and that they needed out and wanted to be at home in the support of their family. And that reality for the patient brought to the front of my attention, like, what some of our patients are facing when they're accessing healthcare services. And I pulled a quote from one of the needs, or from our needs assessment, and it just said, and listen to the stories too, where healthcare providers are all busy. You go out to communities, you have to see X number of people and whatever. You think this isn't good time management if you're not seeing more patients. But sitting and listening and visiting and sharing for a reason. If someone's sharing with you, it's because they think you need to learn, or that you need to know that, and that's important in communities. And so it just kind of resonated with me that it was almost as if the patient knew, like, I'm a young practitioner, I'm gonna give you a lesson here about maybe taking away that bias of like, why would you not stay in rehab? It's like, don't judge me. This is where I came from. This is what I'm experiencing. And they went on to share that they felt comfortable in town, supported by people that they knew better and that they were more comfortable around. They knew that a lot of our staff members had actually been out to community where they live and seen their homes and visited with other neighbors, and knew what they were facing in terms of accessibility and transportation post-stroke. So from there, we provided the space for the patient to come multiple times a week, and we stopped in at their house when we were happening to be out in the community visiting. And we just did our best to provide the volume of input that we know they need post-stroke in the best way that we could, provided that their cultural needs were respected and valued. So it's not always been clear or easy in some of those ways to get that that input for neurological conditions that, again, we know is the best in terms of volume and amount. And it does require our services to be flexible to the patient's needs. But honestly, if I could sum up the biggest lesson I've learned in the last 3 years for culturally responsive care, it's just slow down, listen. The most valuable thing we can give our patients is not always our expertise or our education, but just our time and unbiased, non-judgmental, active listening ears. Because really from that point on, we can then utilize our training to work towards their goals, build real relationships that have foundations for that collaborative process that's ongoing, because we know that the stroke journey is lifelong. So building that foundation early of trust and understanding and recognizing where our patients are coming from, I think sets the base for the process ongoing. I'll kind of wrap it up. There was one other statement that I think really just sums it all together that came from our needs assessment as well, when they were talking about the importance of having a culturally responsive framework in our therapies program. And it says, you got to know the people, you got to know the culture, their traditions, you got to be able to mingle with the people. To go and knock on the door and visit them, you got to learn how our people live before you go stepping in and telling them how you want them to live. You don't tell them how you want them. They're going to tell you how they feel they should live. So I just thought that was kind of sums all that up together quite nicely. And that was a direct quote from one of our community members. So that's that. And I've linked the, sorry, Ashley, I didn't send the link to the needs assessment to you, but if you want me to, I can. I just put the little snippet there of the article. There we go.
Thank you so much for sharing your experience and your story and like reminding us, or I think too, it's nice to have the freedom to not feel pushed all the time to do all the tasks that need to be done, but kind of remember to follow the pace of our patients. And I think even in our experience in Saskatoon, and Tanya, maybe you've experienced this too at rehab, we service the north, and it is lonely for people to come here, and their biggest supports are at home. And yeah, they're stuck here, and we do think, boy, you'd be best served, or the best chance of having a good functional outcome is to head over to rehab. But when they look that they've been at RUH for 2 weeks and then maybe going to be in rehab for 4 or 5, 6 weeks, that can be a really tough sell, to be away from everything that's common and they're normal. So yeah, good. Like, thank goodness for places like All Nations Healing Center and the care that you can provide to this population in these communities. I am going to let people kind of throw some questions into the chat as we go. I know, Swift, there is a question from you guys. Are there any other disciplines employed in your rehab department, i.e. OT, SLP, dietitians?
Yeah, we have an occupational therapist. She's on maternity leave at the moment, but we have her. And our whole health services, actually, we have home and community care program, a diabetes wellness program, the community health program, so all of the maternal child health, and all of that aspect of things. Jordan's principal programming, who obviously, if we get any peds, work quite closely with. That's kind of more OT deals with that more than me. Yeah, so we're quite, again, fortunate in that aspect of things, because we really do have the whole wraparound services. It's really, again, mostly when we need the physiatry and some of the specialist services that a lot of our patients have to go to the city. But we actually do have a visiting nephrologist that comes out and does all the satellite dialysis services. And then telehealth and stuff, obviously, which helps us out if we do need to connect with the city for any reasons as well, too. So.
And do you find it challenging to connect with SHA resources, being kind of in the federal jurisdiction?
Like, yes and no. Honestly, I think over the last number of years, like now since our program has been more established, it's gotten easier for sure. And we do share quite a caseload with Regina, obviously, because anything that's more acute than what we normally handle here and then comes back to home hospital. So I think it's definitely gotten easier over the last number of years for sure, connecting with some of those services now that our program's been established and there's more awareness of what we have available here. So yeah, it's definitely gotten better. And we've even had quite a few from Saskatoon, actually, when patients are coming back that have gotten a hold of us, even from places like the MS pathway and stuff like that. So that's been quite good, actually. I think it's improved for sure over the last number of years.
Do you have any thoughts, Brett?
I had to step out. I'm on stroke call. I apologize. I missed a lot of it. I'll watch
Okay.
it, but I'm getting another call right now. I apologize.
Oh,
See,
sure.
It's ringing. See?
No, I know.
Ringing.
He's so engaged.
To mom.
One question, kind of, can you tell us about your cultural practitioner, what that role is, or who, that person is? Describe that person.
Yeah, so there's a couple actually throughout the building. There's one, we just recently opened Eagle's Nest Primary Care Center. So we have a physician working out of there, and then they have a full-time cultural practitioner. So oftentimes they're different members of some of our various communities that have had, which I kind of find it funny, fitting that my presentation is mostly oral, because a lot of the teaching and learning for our cultural practitioners has been passed down from somebody else or a different elder who's had knowledge and teachings in medicine picking and mixing different medicines and herbs for different teas and stuff. So often the individual, I guess, who is doing that has had some sort of training or mentorship from an elder, from another medicine or knowledge keeper that they're now practicing. So yeah, we have various groups throughout the hospital. One that services our acute care, one that's based out of the primary care center. And then also we have like White Raven Healing Center, which does more with the social work aspect of things and addictions. Oh my gosh, I'm like, there we go. And addictions counseling and all that kind of stuff. And then also some of that, they go on medicine picking trips together and stuff as well. And like offer smudges and sweats for staff and patients. Again, we're kind of obviously well set up here for that because we do have a sweat lodge right on the hospital grounds, as well as there's a cultural room on the acute care unit that has proper ventilation for smudging. And as well down here on our side as well in the health services area, they have a cultural room with same thing. You can, with proper ventilation and stuff for smudging and some of the more traditional medicines and stuff.
So for the sites that don't have all of those like capabilities, or from your experience in speaking to patients who have come back from being at one of the other sites, is there any, other than kind of some of the real key points that you've already shared, is there any takeaways or reminders that we should consider in terms of being, culturally responsive to our patients?
I think the other thing is don't be afraid to ask. Like, I think that people, we're so worried oftentimes that we're gonna step on somebody's toes or offend somebody because we don't know. And in my experience, like when I just ask, people are happy to share because it's demonstrating that you're engaged and you want to know more. I had a lady who had a total knee replacement, and she was, before I saw the scar, she told me that she was putting bear grease on it, and I almost jumped out of my skin because it was very fresh, and I was like, oh no. And she showed me her scar looked amazing, and I was like, oh my gosh, like, who told you this? When did you start putting this on? She was like so excited to start telling me like how she mixed it up and where everything came. And so, and just like some things like that. And another woman who's had, her hair was all the way down. I said, when was the last time you cut it? She went on to tell me that she's only got it once in her life ever. And that it was when her grandma passed away. And so the more I just ask, the more people are willing to share, and the more I learn, and the more it helps me not to put my foot in my mouth in some situations where somebody else told me this once, so it's kind of ringing a bell now. So I think that's the other thing. Just don't be afraid to ask, because most of the time people are really happy to share. And if they don't want to, they won't.
Thank you. Thank you, you guys. Thank you both, Tanya and Katie, for sharing today on shoulder pain and culturally responsive care. This has been a great session. I hope everyone can agree. And
There's a couple more questions.
oh, there's a question.
I don't have any. I was wondering
oh
if
yeah.
anyone
Is there
has
any other
more.
questions before we
For
kind of
either.
wrap up?
Now's the time.
Okay.
Safe place.
Safe
You
place.
can put it in the chat
Are
if
we
you're
gonna-
nervous.
No, because it's only a recording.
Sure, sounds good.
You guys, would anyone mind just could everyone turn on their cameras for like just a few seconds so we can kind of get,
Take
if
a
you're
photo.
comfortable, take a photo of a group photo of, yeah, there's somebody.
Early adopter. There we go.
Yeah.
It's a race now. It's a race.
Who all is involved here so we can get to see the community. Oh, your beautiful faces. You're real people. Yay. This is so great. So just so you guys know, next week, Accreditation Canada is coming to Saskatoon. Every 4 years, we try to get stroke distinction to show that we are providing kind of great care to all of the province. And so our excellence and innovation project that we did is this, copying cases, because I think it is kind of a neat initiative that's not done in the rest of Canada. And so we want to prove that you guys are actually here. And it is great to see everyone. I love this. And anyone interested in what the viewers' choice is for December? Anyone? Interested? I can see your faces. So, okay, thumbs up, smiley.
Good.
It's gonna be good. We are gonna cover young stroke. We're gonna cover young stroke etiologies. We're gonna cover some of the interesting things that are a little bit unique to young stroke, post-stroke, getting back into community. We might even cover sex. I'm just saying, not only appropriate for young stroke, appropriate for all strokes. But kind of an interesting topic that we probably don't talk about enough with our patients, but they are interested in hearing about. So, thank you for joining us today. Look forward to seeing you next month. Hopefully the one link that Ashley has sent will work, but please bear with us if a few emails come out.
It's a good reminder. It's a
Good reminder. Good reminder.
It was way too much, and I almost cried about it at home. So embarrassed. I'm really sorry.
Look at all these people. Like there's like that place.
Yeah, I know
I
everyone's like.
There's like 45 people in that one square.
Yeah, look at it's so great to see everybody.
I'm again really sorry about the emails.
Who are these guys? You guys, oh, Swift Current. Yeah, look at all of you. Get it. Well, and these guys too have like 3 or 4 people in there.
Yeah.
Who is this? Crystal Toth. Where are you from? Oh, our RTs.
Yeah.
I think these guys are going to be presenting in
It's gonna
February.
be our February.
Yeah, cool. Look at all the people. Estevan, we see you. I feel like Romper Room. That's dating me. Anyone remember Romper Room? I see Tracy and Kate. Okay, anyway, we digress. We will see you guys in a month. In December. Christmas. I can't even. For some young stroke. Okay. Thanks for coming, guys.
Thank you.
Thanks, everybody.